Thank you very much. That's a great honor to be introduced by you. Today I'm going to present to you one of my implementations in healthcare. It was when I was finished my ophthalmology residency, and I was invited to work in the hospital. And I'm going to present to you how I use these tools, the 5 focusing steps, and the drum buffer both with the buffer management to improve the practice. So let me show you where I'm from. I'm from Brazil, I'm from Salvador. And when I was finished my residency in ophthalmology, I was invited, as I mentioned earlier, by the chief of retina at the hospital to work there. And I was taking his place in some exams, performing some imaging exams. And these are the exams, the Fundus photography. This is my right eye, actually. And the fluorescent angiography. This is not my eye, fortunately. Well, when I started, at the first week, he recommended me to start with less patients than he used to. And so I could get the pace, and I started with only 8 patients. It was great, big time, and then I moved to his regular schedule, which was with 12 patients plus about 2 extra patients he requested me to attend to. And then the chaos went into the system. It was really a problem. Our team was composed by a provider, which was me, an assistant, and a nurse. And the idea to implement TOC was born when I was going to have a lunch, and I heard the assistant talking to the administrative, asking about the schedule, who is going to support me. And she said, "Oh, it's you." And then she said, "Oh my God, what happened? Is it so bad to work with me? I can't believe it. Why is that?" "Oh, doctor, don't worry, that's not it. That's because it's horrible to not give you all the support that I wanted to give to you. That's why. That's because we can't help you out so much as we wanted to." Okay, I was feeling that there was a really problem there too. I was really frustrated because I wanted to do the best job, but we are not able to do that. I'm gonna tell you why. Well, first, the fundus photography. This is the patient flow. The fundus photography was composed by when the patient got into the hospital. The patient always had to have the pupils dilated to do the exam. So we must wait around 20 to 30 minutes to complete the dilation process. And then the patient was going to the photography itself, and then I wrote the report and give to the patient. When the patient was there for the fluorescent angiography, it was almost the same, but we had to obtain the venous access. So then we could make the photograph, and then I would write the report and give to the patient. It was interesting it's very important to mention that it's not usual to give the report at the same day. Not in Brazil, not even in Portugal too. So what were our undesirable effects? Well, this is the structure where I worked at, and this is the waiting room, and this is where I used to perform the exams, and there was another smaller waiting room there. So when a patient arrived, she had to dilate the pupils, and as I mentioned, it used to take 20 minutes at least. So the problem was that I had to wait because I was supposed to arrive at 2. I used to do that in the afternoon. I was supposed to arrive at 2, and the patient 2. So I had to wait 20 minutes for the patient to dilate the pupils. It was all horrible. Then there was another problem. When I had the patient, and the patient was ready to go to me, okay, I did the exam, but when I finished the patient, I had to wait for the assistant to refill with another patient. So the assistant was doing a lot of things too, and she was not able to see the patient going out of the room, so she could take another patient to me. It was really a problem. Okay, then I did the photography. It was okay, but sometimes I didn't have the medical record. The medical record was missing. She didn't bring me the medical record. I had to go after her and ask for the medical record. She was somewhere around here, or taking the patients in the reception area, or maybe taking the report which was printed in another room, as I'm going to show you. So I had to wait for the medical records too. And then when we had a patient to do the fluorescent angiography, I also had to wait. Why? Because the usual procedure was to take the patient to the room and then ask the nurse to get the venous access and to inject the dye, because we used that dye to do the exam. And I couldn't inject the dye and run to the device to take the photograph, because I needed to record the flow of the dye within the eye. And I was supposed to watch the patient because it could exist an adverse reaction too. So we needed a nurse there at the moment of the procedure. So I had to wait for the nurse to come from the operating center to this room, to my room. So I had to wait. Okay, and as I mentioned, there is the printer that it was a special printer to print all the photographs with a high quality, and also the reports. And it was far from this area, and the assistant had to go there to take it and then bring the report to me so I could sign it, and so she could give to the patient. Well, why we needed to change? As I mentioned earlier, we had staff dissatisfaction. Not only the assistant and their nurse, but also me. We were all dissatisfied with this situation. I had to wait a lot. I was constantly idle because I had to wait for the prepped patients, I had to wait for the medical records, I had to wait for the nurse. I was underused there. And also, the patient had to wait a lot because all of these problems. So we needed to change. And what we needed to change? We needed to, what we need to change? We were working based on local efficiencies. The assistant was always occupied, and I was also almost occupied because I had someone in my exam seat, but the patient was not ready because didn't have the venous access, or because I didn't have the medical records. There was something missing and I had to wait, but I was supposed occupied. And then we, instead of focusing, we should work, we were working based on local efficiency instead of focusing on balancing the flow of the patient. That's the problem we needed to fix. And we didn't have a list of priorities. I didn't know what was the next patient. I needed to have an answer for that. I needed to answer who is the next patient I should attend to. So our goal was to provide an excellent and timely care for the patients at a surplus now and in the future. That was our goal. I started defining it. And also we had a necessary condition. We had to provide a secure and satisfying environment for the employees, for the staff, and for me, and for the nurse, now as well as in the future. So, what were our measurements? These were our measurements. I didn't use the throughput accounting. I just measured how many patients we were able to attend. We used the appointment slots available per session and the last minute appointment slots. It was not used to the patient for us to have a no-show. So I used these. So, and then I used the 5 focusing steps to achieve our desired results. So let's see how I did it. Well, the first step was to identify the constraint. What was the constraint? Well, I could see that there were a lot of patients just waiting after me, so I was the constraint. But it's not only that. I was also the strategic constraint. I was the most scarcest, skilled and expensive resource there. So we had to do it better. I had to exploit me better. So how could I exploit me? How could I exploit myself? Well, we had to realign the whole system to make me be fully utilized and performing only high-level skill tasks. So, and I should never stop due to lack of prep patients, missing medical records, or waiting for the nurse to obtain the venous access and help us give support for the procedure. So, I, based on these concepts, I decided to change the schedule too, because I needed to change this first patient appointment, mostly. And I, instead of using this scheduling model, which was one patient every 15 minutes, I changed it to 15 patients plus 2 acute. But there was, it's not there because of the projector, but it's okay. We have the patients divided into 3 groups of 5 patients each. You was supposed to have parentheses here separating these groups. So the idea was to have this wave of patients, with the first wave of patients arriving 30 minutes earlier. So I was sure that I would have at least 1 or 2 patients waiting for me already prepped when I arrived at 2. And when I proposed that, when I asked the schedulers that to do that, it was, "Oh, doctor, are you crazy? It's not possible because you have 12 patients and it's already a mess, it's a chaos, and you want to increase to 15. Oh, it's not gonna work." And I said, trust me, it's going to work. So, how could we solve the lack of medical records? The solution that we came was to have all the medical records gathered before the session starts. And I also asked the assistant to put all of them in the order of the patients I should attend to. So she had all the medical records in her hand or somewhere else. And when she, as soon as she takes the patient to me, she gives also the medical records in the order. So I was able to answer this question: who is the next patient that should attend? So let's see how it happens too. This is another change. these 3 chairs, I use it to make a buffer. So I put patients here waiting for me, and when this patient leaves, I was able to ask the other patient. It was great because I could see the patients and I was not waiting anymore for the next patient. So the step 3, subordinate everything to the above decisions. Well, as I showed you, I created a buffer just before me to protect me, and I use buffer management, as you can see by the colors. And so I was able to see who were the next patients, and also the assistant was able to see when she needed to refill to the patients, this buffer. So if we had all the 3 chairs occupied, the buffer was full, and she doesn't have to do nothing. She had to do nothing. So if we had 2 chairs occupied, we had the buffer consumed, and she needed to do something in a near future. And if we had only 1 patient sitting there, she could know that she should refill the buffer, and she should do something. And if we had no patient there, she should do something immediately. It was great for her because she was not supposed to see when the patient leaves the room, and every time she was free to do other things instead of only be watching the room, how many patients I had. It was great for her. Such a relief for her. And I also solved the problem for waiting for the nurse. How? Instead of obtaining the venous access there, we used this big chair here to get the venous access. And when the patient was ready for that, with the venous access, we could take the patient to the exam room. Would go just as soon as the venous access was ready, and it was great. Nobody had to wait anymore. And as you can see, the DBR elements are all here. I was the drum. I had a buffer just before me, and the rope was the scheduling system. I was able to choke the release of the patients. I was able to control how many patients I had, and it was great. Why? Because I started with 12 patients, then I was able to increase in the future for 18 patients plus 2 acute patients. It means I had a 50% increase in the number of regular appointments, and I also had a 150% increase in the number of acute patients. And it was only in 4 weeks. It was great to increase the number of patients. And we had other results as well. The staff satisfaction was really good, increased a lot. We were also able to increase the quality of care because I was capable of spending more time with each patient there, instead of going after the assistant to know what is the next patient, to get medical records, and all of it with no additional costs. We didn't invest anything there. We did the step 4 too. The hospital bought a new machine which was able to do the exam without dilating the pupils, and it could be performed by an assistant. This machine was used for less severe cases, and then there was a problem. I'm gonna show the problem with lessons that I learned with this case. I moved from Salvador to Portugal, and when I did that, the system went back to the chaos. because I did something wrong. I did not educated them, the people there, to TOC. I explained some concepts, okay, but they were not educated, they were trained. And these, they were not capable of maintaining the process there. And so we went back to the caves. I spoke recently with the chief of retina, and he told me that. But I can present to you this conclusion that I'm sure that TOC can generate breakthrough improvement in healthcare, at least in ophthalmic imaging practice, as you could see here. Well, it was a pleasure presenting to you, to be here, and now I'm open to questions. We don't have mics.
So, Gustavo, one of the more interesting problems, I think, in healthcare, it's the perceived conflict between the demand that we know that is there, and we know that we have a lot of patients that we should be treating earlier in the stages, getting first care attendance and so forth, and some visions that healthcare providers have that they don't have enough demand. So you go to the hospital and say, oh, do you have a bottleneck in your surgery rooms? And say, no, I don't have wait for my surgery room. And then we look at our personal experiences and say, how come I cannot get a surgery for months? And they tell me they don't have queues. And it's the same thing when you go for practices and you want to see a doctor. I want to see my urologist, great, but only in 3 weeks or 4 weeks. Oh no, I don't have bottlenecks, I don't have capacity constraint. How do you, in your personal experience, and now looking through the lenses of TOC, see that apparent contradiction?
Well, that's interesting because, as you mentioned, we have capacity for that, but we have also these queues, these huge queues. Sometimes it's a marketing problem that some services, some practices don't have enough patients to create a huge queue, but I think that most of the services, if not all of them, have extra capacity that they could use to improve in decrease these huge queues you were mentioning. As I was able to do here, we had a waiting list, a backlog, that we were able to reduce a lot. And if you you've noticed, but we created here, with this breakthrough improvement, we created a competitive advantage here, because there was no other service, no other practice that was able to attend the patients as fast as we could and to provide the report, the exam result as fast as we could. That's why I think that we have extra capacity which is not used, as we can see with a lot of TOC implementations in other areas too.
Any other questions? Thank you.